So next topic is obstructed labor and rupture uterus. What is obstructed labor? It results when mechanical causes prevent the fetus from descending in spite of good uterine contractions. What are the causes of obstructed labor? The most important cause is cephalopelvic disproportion. That is when the pelvis is small or the fetus is very big. Both this is the reason for cephalopelvic disproportion. Then in malpresentations like a transverse like breech, bro presentation, all this can lead to an obstructed labor and rupture, sometimes rupture. Soft tissue dysplasias like a fibroid in the lower uterine segment, cervical dystocia, ovarian tumors, uterine anomalies. Fetal anomalies like hydrocephalus, fetal ascites and fetal tumors. What are the risk factors? One is short stature, then a teenage pregnancy, young patient the pelvis will not be developed, then uncontrolled diabetes, then the baby will go for macrosomia. Lack of transport facilities, so when a patient with a CPD is referred and when there is lack of adequate transport facilities, the patient may go for obstructed labor. Then lack of access to health facilities, certain tribal areas if they are remaining at home. What is the course of labor in obstructed labor? Normally, during the course of labor, there will be a demarcation develops between the contracting upper segment and stretched lower segment. This demarcation is called a retraction ring. When there is obstruction, the ring becomes prominent. It is called a Bandl's ring. And so the lower segment will get stretched thin and friable. Then the bladder may get compressed between the head and the pelvis, and sometimes pressure necrosis of the bladder can occur, and this can lead to a later vesicovaginal fistula. And finally, the lower segment will give way. This is called the rupture uterus. This is a course. So what are the clinical features in obstructed labor? On general examination, the patient will be anxious and exhausted. She will be dehydrated. There will be tachycardia, tachypnea, that is pulse rate will be more, respiratory rate will be more, and sometimes because of prolonged labor she can have fever. Abdominal examination, the uterus will be tonically contracted, and you can sometimes see the retraction ring or the Bandl's ring over the abdomen. In case of rupture, sometimes the contour will be absent, and the fetal parts will be easily palpable. Abdominal examination. PB, the cervix is not well applied, edematous, and a large caput will be present, and there will be irreducible molding. Management of obstructed labor, yes, you have to correct the dehydration acidosis, send blood for investigations, catheterize and record the output. Antibiotics have to be started, rule out rupture by clinical examination and by sonography, and the management is an emergency cesarean. What are the cause of rupture uterus? As we have discussed, obstructed labor is a primary cause, then injudicious use of oxytocics. Intrauterine manipulations like internal podalic version or destructive operation. Over distended uterus, a grand multiparity. Then congenital anomalies, trauma, scar rupture in the case of previous cesarean, previous myomectomy, abortions, hysterectomy. Clinical features, sudden cessation of the uterine contractions for a patient who was having contractions, and the patient will be having a feeling of something giving way, and there will be tachycardia, hypotension, hematuria and fetal heart changes. There will be signs of intraperitoneal bleeding. The differential diagnosis, abruptio placentae, rupture of the liver. These are the complications in rupture. Maternal complications like hemorrhage, shock, DIC, renal failure, extension to the adjacent structures, and maternal mortality. The fetal complications include perinatal mortality and hypoxic ischemic encephalopathy. Management, immediate laparotomy in suspected scar dehiscence or rupture to save the mother and the baby. If already rupture diagnosed, stabilize the mother with IV fluids and blood. And laparotomy has to be done to repair the rent and hysterectomy. Look for injury to the bladder and ureter.